So, wish you all a very good evening, respected seniors and my dear colleagues. With your permission, I begin the presentation of today's topic titled Beta Blockers in Hypertension and CCS. Now, at the very onset, before delving further into the detailed discussion of both of these indications and the role of beta blockers, let us set the agenda for today's meeting. Now, essentially, when we talk about CCS, essentially a very popular term nowadays, the chronic coronary syndrome, essentially what we might call the combination of the chronic stable angina, the microvascular ischemia, and vasospastic angina. And obviously, the major component of this would be the chronic stable angina. And in this area, in chronic coronary syndrome, the role, the importance, the relevance of beta blockers are essentially absolutely beyond the ambit of criticism. Essentially, meaning the role of beta blockers in morbidity and mortality benefit in CCS is very well established. Of course, we will be discussing still the role of beta blockers in CCS, not only the role of beta blockers but also understanding the interaction between the different classes of agents that are used in the management of CCS. Essentially, if you're using your beta blocker as a first line agent, what should be the second line agent, when to add on, when not to add a dihydropyridine calcium channel blocker, or for that matter, when to add what we call the cardioselective or the rate limiting calcium channel blockers. If you're using the third line agents like a long acting nitrate or an ivabradine or a ranolazine or a trimetazidine, when to add to it. So essentially, we understand the central role of beta blockers in the management of CCS, but we will be undergoing a critical appraisal of the same. On the other hand, the first part of the discussion would be pertaining to the role of beta blockers in hypertension. Now, this would be a critical area of discussion because, as we understand it, in the present era, beta blockers in the management of hypertension tends to have lost a bit of steam, right? Most guidelines in today's world would recommend your initiation of therapy with a ACE inhibitor or ARB. More often than not, the second line agent would be a calcium channel blocker. More often than not, according to the guidelines, the third line agent would be, I'm getting a chat. One sec. Right. More often than not, the third line agent would be a thiazide like diuretic. Depending on the potassium values of more than 4.5 or less than 4.5, the possible agent, if the potassium is more than 4.5, would probably be a alpha blocker, and somewhere the role of beta blocker in this particular step comes in. If the level of potassium is less than 4.5, of course, we will be using a mineralocorticoid antagonist. But we do understand that your beta blockers, according to most guidelines, it's really falling away from the first or the second or third line indication. Now, what we will obviously do is understand the critical appraisal of data to evaluate the role of beta blockers in certain situations, at least in a particular subgroup of patient. We'll try to analyze whether there is actually a difference between the younger hypertensives and the older hypertensives in cases associated with CAD and hypertension. We'll understand the role of neurohormonal activation in the management of hypertension and really understand whether the losing steam of the beta blockers that has happened over the past few decades, whether there needs to be an appraisal of the same. So without much further ado, we start our discussion with understanding the cardiovascular continuum role of hypertension and CAD. Now, at the very onset in this lovely animation, what we will need to understand is okay, this is a Zoom session. Is there a way to annotate this? Pronamendo, there's no option to annotate this because this is Zoom. I'm not getting an option to annotate this. Usually on Zoom, annotate this right on the screen, because in Zoom we can annotate. There is no option to annotate on the screen, to write or mark on the screen. Is there?
Is there any option is featuring in your screen, sir?
No, I can't see this. It's a separate option on Zoom, but I don't seem to have this here. But not an issue. It's a very clear slide. Not an issue. It's a very clear slide. Not an issue. So what we need to understand first and foremost is understand that the myocardial infarction, you might call this a central event. We might call this the most important event. But do understand the myocardial infarction is not the terminal event. Neither it is the first event. It's just a central event. So if you go backwards in time, your myocardial infarction, if you go back in time, essentially it would start from the development of the risk factors like hyperlipidemia, hypertension, diabetes, smoking, essentially leading to atherosclerosis, left ventricular hypertrophy, ultimately developing into your coronary heart disease and then myocardial ischemia, where there is a demand-supply mismatch of the blood requirement of the cardiac musculature and essentially coronary thrombosis and myocardial infarction. And ultimately, one of the primal causes of death from myocardial infarction, if there is no sudden cardiac death, would be arrhythmias, VTAC and ventricular fibrillations being the cause of sudden death. Essentially why beta blockers have such an important role in post-MI patients, reducing the risk of death from cardiac arrhythmias like VTACs and VPIVs. Ultimately, remodeling ventricular enlargement, essentially here where the role of ACE inhibitors and ARBs are primal in combination with beta blockers. Ultimately, heart failure, where also we know that beta blockers have mortality benefit, ACE inhibitors, ARBs have mortality benefit, spironolactone has mortality benefit, ARNIs, a very popular group of molecules now, have mortality benefit as well, and the final event being death. So beta blockers in hypertension, and we will now understand the critical appraisal of the literature that we have, and we'll try to resolve the controversies pertaining to role of beta blockers. Now, trends in the number of adults aged more than equal to 18 years with raised BP by region, what you will immediately notice, it's a slightly busy slide, but what we'll immediately notice that a huge contributor are from this orange and the yellow ochre colors, and these are Asian parts. This would be South Asia, Southeast Asia and East Asia. As you can understand from this entire world contribution, such a huge contribution from Southeast Asia. We're talking about India, we're talking about Pakistan, Bangladesh, Sri Lanka, Maldives, and we are talking about Eastern India, East Asia, of course. A major contributor would be China, and such a huge contributor to the world mortality. The number of adults with raised blood pressure increased from 594 million in 1975 to 1.13 billion in 2015. Really 113 crore the population we're talking about. So approximately the population of India in 2011, the census, Indian population was 1.21 billion. So you can understand, and such a populous country, second most populous country in the world. So the total number of hypertensives in the world is almost 1/6 of the world population at this stage. Incredibly high numbers. Hypertension is one of the leading risk factors for global mortality, accounts for approximately 50% of all deaths from stroke and heart disease. We do know that, of course, hypertension is the major contributor to cardiovascular death, and indeed cardiovascular death is the commonest cause of death throughout the world, commonest cause of death in developed nations, also the commonest cause of death now in India as well. Responsible for 9.4 million deaths worldwide every year. Cardiovascular disease risk doubles with each 20 by 10 millimeter of mercury. We are not talking about huge numbers. We are talking about a difference of only 20 millimeter of mercury systolic blood pressure, 10 millimeter of mercury diastolic blood pressure, and with that the risk is doubled. It becomes 100% more. It becomes overall, so it becomes 200% is the death, with only a minuscule rise systolic blood pressure 20 and diastolic blood pressure 10. Clinical outcomes of BP reduction, yes, with only 10 millimeter. We are looking at, look at the numbers. We are looking at basically single digit BP reduction. We are looking at 10 millimeter, just 10. Look at 5 millimeter reduction in diastolic blood pressure. We are looking at just almost single digit BP reduction, and look at the reduction in cardiovascular death. 13% reduction in cardiovascular death if you're reducing the SBP. 14% if you're reducing the diastolic blood pressure by 5. Look at the reduction in the stroke risk as well. So with very minuscule, very small amount of BP reduction in each of the components, in the systolic blood pressure or the diastolic blood pressure. Huge improvement, ridiculous improvement, I might call it, for the lack of a better term, in cardiac mortality data. Important clinical point, underlying mechanism of hypertension differs between the young and the old, and this becomes important. What we will of course find is that the diastolic blood pressure increment is the sine qua non issue with a young hypertensive. The systolic blood pressure rise is a more prominent finding in the old patient. Yes, if the difference is the systolic is more than equal to 140, diastolic less than equal to 90, we have a very popular term for it, isolated systolic hypertension, a pretty common issue among older hypertensives. So yes, if you're looking at the main mechanism in the younger patients, increased peripheral resistance ultimately leading to higher diastolic blood pressure compared to systolic blood pressure rise is a feature of younger hypertensives, whereas in older hypertensives the main mechanism is aging leading to arteriosclerosis and atherosclerosis leading to a systolic blood pressure rise. Often isolated systolic hypertension is a common feature in the older patients. We'll try to highlight and understand the role of the different antihypertensive agents in hypertension. So beta blockers, our today's topic of discussion. The mechanism of action is of course by reducing heart rate by blocking the beta 1 receptors and reducing cardiac output. Cardiac output is, as we know, the multiplication of the stroke volume and the heart rate. So essentially, if you are reducing the heart rate, the cardiac output reduces. Also reduces the renal release and the sympathetic activity as well, what we call the neurohormonal activation cascade pathway for development of hypertension. Diuretics, kindly note that we sometimes have a tendency of using high ceiling diuretics as antihypertensive. Kindly note that high ceiling diuretics like furosemide, bumetanide, these are not antihypertensive agents. Yes, these might be agents in patients of heart failure with overload, but per se these are not antihypertensive agents. The prominent and diuretics with excellent evidence base would be the thiazide like diuretics, which are very popular molecules now and across multiple guidelines, third or fourth line agent in uncontrolled hypertension after use of ACE inhibitor or ARB and calcium channel blocker. So essentially it would be your chlorthalidone, metolazone, indapamide and so on and so forth. And diuretics increase the excretion of sodium and water. And the angiotensin receptor blockers inhibit vasoconstriction, body fluid retention and sympathomimetic action. The ACE inhibitors act on the renin-angiotensin system in a similar way and reduce blood pressure by suppressing the tissue angiotensin levels. Calcium channel blockers block the influx of calcium into vascular smooth muscle cells and reduces peripheral vascular resistance, thereby decreasing blood pressure. Essentially, when we are talking about calcium channel blocker as antihypertensive agents, of course, we tend to be in the dihydropyridine type of calcium channel blocker like your amlodipine or cilnidipine or in today's world benidipine. But the rate limiting calcium channel blocker or the cardioselective calcium channel blocker like verapamil and diltiazem, they have a prominent role to play in CCS, but as antihypertensives, in at least today's world, the data is extremely limited. Going on, this is a data from Lancet, a paper from Lancet. So, should beta blockers remain first choice in the treatment of primary hypertension? Meta-analysis. We'll read this, but we'll try to understand the fallacies. As you can note that this is a pretty old paper from 2005, a critical appraisal of the role of beta blockers. But issue is a lot of data, particularly a decade-old data from pertaining to beta blockers in hypertension. Atenolol is a molecule that was rigorously studied, but whether the same can be said about the more prominent molecules in today's world, including but not limited to bisoprolol, we will try to understand this, whether the data and the evidence that we have from atenolol that can be extrapolated in a larger way to bisoprolol is something we are trying to evaluate. In comparison with other antihypertensive drugs, the effect of beta blockers is less than optimum with a raised risk of stroke. Hence, we believe that beta blockers should not remain first choice in the treatment of primary hypertension and should not be used as reference drugs in future randomized controlled trials of hypertension. What we might call pretty damning data for beta blockers. But what were the problem of this statement? And why were the results so disappointing? Now, problems with atenolol. Most of the trials in the meta-analysis discuss uses atenolol. Further, in most of the trials, atenolol was used in once daily dosage. But is atenolol a truly 24-hour drug? No. Whereas ideally it needs to be taken more frequently. The half-life of atenolol is 6 to 9 hours, so it will really work best as a BD molecule, twice daily molecule. Atenolol, when taken daily, leaves the patient unprotected in the last 6 hours of a 24-hour period. It is possible that this may have contributed to the results observed in clinical trials that uses atenolol to treat hypertension. Of course, the metabolic side effects, as we know, especially atenolol, have well-known metabolic adverse effects, particularly the impairment of glycemic control. Not only that, there are issues pertaining to the sympathetic overdrive that we are not discussing now. The difference between the older and the younger patients. So, is it a fit for all, or in younger patients, whether there is a particular role of beta blockers? We'll try to analyze. With this slide, I really needed annotation. This is a busy slide. Without annotation, pretty difficult to explain. Pranamil, if you can help me with this. Wait. But let's look at this. Patients younger than 60 years, and what we say, look at the risk ratio. We are obviously talking about the adverse effect profile. Now look at the risk ratio. What is it? It is 0.97. Look at the confidence interval. It includes 1. So if your confidence interval includes 1, so your risk ratio is 0.97. Essentially, there is no statistically significant difference between the two. That is what it means, right? Look at the confidence interval. It includes 1. Whereas, if you're looking, so essentially, if you're looking at the adverse effect profile, the adverse effect profile of a beta blocker in younger patients, younger less than 60 years, is the same as that of placebo. This is what it means. Statistically, this is what it means. If we are looking at patients 60 years and older, and now we look at the risk ratio, then it is 1.06. Importantly, look at the confidence interval. It is 1.01 to 1.10. Essentially, the confidence interval does not include 1. So this is statistically significant. One might look at the p-value and say the p-value is non-significant. This is the test for heterogeneity, right? So this is not the significance level, the probability level of the study itself. So essentially, look at this, look at the confidence interval. So if the data of the two are compiled together, so essentially, even though the adverse effect is not an issue with younger patient, if you collute the data together, then it is a slightly misrepresented data, as we might call it. So what we can clearly see that the adverse effect profile in younger patient of beta blocker is as bad or as good as placebo. This is what it comes. This is what we get from this. So guidelines recommendations for beta blockers, uncomplicated hypertension. If it's moving on to an complicated hypertension, look at this. If the patient with hypertension has arrhythmia, of course, beta blockers are an excellent choice. We've already talked about post-MI patients. In post-MI patient, what is a very important cause of death? It would be ventricular arrhythmias. It would be the risk of development of ventricular fibrillation. It would be a risk of development of ventricular tachycardia. And this is where beta blockers have a very, very good role, right? In coronary artery disease, if your patient of hypertension has coronary artery disease, beta blockers would be probably the most vital drugs you can give the patient. In congestive heart failure, we have already discussed there are hardly 4 classes of agents that have mortality benefit in hypertension, and this is one of the molecules, right? Beta blockers, ACE inhibitor ARB combination, spironolactone, the hydrolyzine and long-acting nitrate combination, ARNIs. These are the only few groups of drugs that have mortality benefit, right? So if you are a patient with hypertension and any of these, beta blockers becomes a very attractive choice. 2018 European Society of Cardiology Guidelines for the management of arterial hypertension. The first drug, depending on the level of BP, if the systolic BP is less than 50 or in very old patient more than 80, you can go for a single drug. Otherwise, it's a very good idea to go with a combination of agent. So initial therapy dual combination ACE inhibitor ARB along with calcium channel blocker or diuretic, and this is classically what we do. This is classically what we do, right? If you are getting your patient and the patient is relatively young, less than 80 years of age, and the SBP is more than 150, more often than not, we go for a combination of drug, and that is what the recommendation is according to ESC. Of course, if you look at other guidelines, including NICE guidelines, and I'm a big fan personally of NICE guidelines, NICE guideline would recommend a stepwise approach of addition, whereas step 2 would be a triple drug combination. Now, let us once again, even according to ESC consensus statement, let us look at the specific indications of beta blocker. So if your hypertensive patient has any of this, including your heart failure, angina, post-MI patient, atrial fibrillation patient, or younger woman, or planning pregnancy, in any such case, and this is a wide area we are talking about, a wide area, complicated hypertension, where beta blockers are exceptionally important drugs, whereas antihypertensive in your armamentarium. The potential cardiac benefits of beta blockade reduces inflammation, shear stress, endothelial dysfunction, the risk of plaque rupture, and essentially this becomes an anti-atherogenic molecule, reduces cardiac mortality, reduces heart rate, reduces the sympathetic activity, essentially acting as an antiarrhythmic agent. It's an anti-ischemic agent. It's an anti-anginal drug, as we know, by reducing the heart rate and BP and prolongs diastole. By prolonging the diastole, increases the cardiac perfusion, because cardiac perfusion occurs in diastole, something that we have read in our second years, I believe. Reverses cardiac remodeling along with ACE inhibitor and ARB. So important clinical points, let us summarize now. So underlying mechanism of hypertension differs between the young and the old. So what we see, that the cause of hypertension in young more often than not is increase of peripheral resistance, whereas in older patient it is essentially atherosclerosis and arteriosclerosis. Beta blockers are as good or as bad as other classes in younger patients, particularly if you're looking at the adverse effect profile, metabolic derangement, then beta blockers are comparable to placebo in younger patients. When we are talking about the adverse effect profile, and when we are talking about the efficacy, they are as good as any other class of agent in younger patient. Beta blockers can be used at any step for hypertension when there is a specific indication for the use. And what are those indications? If your patient is a post-MI patient, if your patient has angina, if your patient has arrhythmia, including but not limited to atrial fibrillation, if it's a young woman, if the patient is targeting pregnancy, in any such cases, beta blockers are a very good add-on agent to your already treated patient. And beta blockers are effective in reducing the sympathetic overdrive. The Great India Blood Pressure Survey. We have talked about the global parameters, we have talked about the global guidelines. Now let us have a bird's eye view on the Indian scenario. The overall prevalence of hypertension, 30.7%. Prevalence adjusted for 2011 census population, approximately still 30%. And the prevalence adjusted for WHO reference population, 32.8%. And what we can see that even in a relatively young group, firstly, I hope you realize from our knowledge of public health that India actually has a young population. It's like a pyramid. If you're looking at a country like Japan, the percentage and the proportion of older patient is higher. In the Indian scenario, and for that matter in most developing countries or third world countries, the younger population is a large contributor to the total population. And what we see in a relatively young age group, look at between 20 to 44 years of age, 45 and 54 years of age, 55 and 64 years of age. Now look at the prevalence. It's almost reaching 50. Someone between the age of 45 and 64 would be a relatively, particularly a 45-year-old person with hypertension would be called a young hypertensive. Now even in such a population group, see, look at the percentage, it is almost reaching 50%, right? So that is how high it is. Young hypertensive are indeed a very good proportion, a very high proportion of total hypertensives in the Indian scenario. So the self blood pressure measurement as compared to office blood pressure measurement in a large Indian population, the India Heart Study. And once again, what we see in firstly look at the heart rate. In each case, what we are looking at the different groups. What we are trying to analyze, in different kinds of hypertension or even in normotensive patient, whether the patient is normotensive, whether the patient has hypertension, whether the patient has something called the white coat hypertension is what we know when the patient reaches the doctor's clinic and that white coat and the white apron of the doctor produces the sympathetic hyperdrive and the sympathetic overactivity, which is producing the high blood pressure. It's essentially why now home blood pressure monitoring and ambulatory blood pressure monitoring have become very important tools in assessment of hypertension in today's world. Masked hypertension. Now look at this on an average, look at the heart rate across parameters, across subgroups, across segregations, it is more than 70. Once again, I have something in my chat. Right, we're already getting a few questions, but we'll take care of this at the end of the session. Moving on. So mean age less than 45 and the mean heart rate, yes, in all cases more than 70, so more than 80. Elevated heart rate increases the risk of elevated heart rate increases the risk of mortality in young patients, increased mortality risk with increased heart rates among Frenchmen according to age. Now what we are trying to find is that if you're looking at heart rates more than 100, look at the relative risk of death. It is 3.13, 3.23 and 2.75. We are talking with the deep blue one or the Prussian blue one, as you can see, is the coronary heart disease and the patients having heart rate more than 100. The green one is the cardiovascular disease and the blue one is the all cause. Obviously, it's not a summation. We are talking at the relative risk. Now, what we clearly see as visual impression from this is that if the heart rate is between 60 and 80, then the relative risk of death is pretty low. If it's on between 80 and 100, the relative risk of death is higher. And if the heart rate is more than 100, clearly it keeps on increasing. The higher the heart rate, higher is the chance of death in a patient of coronary heart disease or cardiovascular disease. Clear-cut representation of data. So we need to reduce the heart rate in patients with hypertension, in patients with congestive heart failure, in patients with coronary artery disease, in patients with any cardiovascular disease. Yes, heart rate is a very important target. Resistant hypertension in clinical practice in India, the Jaipur Heart Watch. The present study shows that 1 in 5 patients with hypertension in India have resistant hypertension and need multiple drugs to control the BP. The prevalence is similar to previous reports from India and more than the prevalence in global studies. Is something that we've already seen. So resistant hypertension, look at the change from your 2013 to 2018. 2013 really, we were talking about mineralocorticoid receptor antagonists like spironolactone. We're talking about amiloride, the alpha-1 blocker doxazosin, and no other beta blocker. But here 2018 European Society of Cardiology recommendation, look at this, resistant hypertension, recommended treatment, and this is grade 1 evidence. Recommended treatment of resistant hypertension is the addition of low dose spironolactone to existing treatment or the addition of further diuretic therapy if intolerant to spironolactone with either epinephrine amiloride, higher dose thiazide or thiazide like diuretic or a loop diuretic or the addition of bisoprolol or doxazosin. If you look at the ESC recommendation, it is bisoprolol that is given. We have not really mentioned beta blocker. So I already found a question pertaining to selection of beta blocker. We are not really pitting one beta blocker against the other. At this point, we are not really discussing the comparison between the cardioselective beta blockers like your bisoprolol or carvedilol, which is a dual blocker, or metoprolol, or for that matter nebiprolol. We are not really doing that. But look at the recommendation for resistant hypertension. This is grade 1 evidence. It does not mention a class. It mentions one particular beta blocker, and that is bisoprolol. So important clinical points. Underlying mechanism of hypertension differs between the young and the old. Beta blockers are as good as other classes in younger patients. Beta blockers can be used at any step for hypertension when there is a specific indication for the use. Indian patients with hypertension are younger and have a high sympathetic overdrive. As we've already seen, we looked at the average pulse rate, more than 80. The prevalence of resistant hypertension in the Indian patient is 20%, very high, much higher than the global average. Bisoprolol is an additional drug recommended for the treatment of resistant hypertension. So yes, the previous choices remain, but in the 2018 ESC consensus statement, grade 1 evidence would be addition of beta blockers. Combination therapy in hypertensive management, we know the dotted ones are the ones that we would often try to avoid. The deep red ones are the ones that are recommended. As you can see, your ARB and ACE inhibitor along with calcium antagonist, that combination is obviously a very ideal initial combination. But look at this, whenever we are talking about the other agents, including your alpha blockers and so on and so forth, beta blockers along with calcium antagonist, and obviously in this case for anti-hypertensive action, we are indeed talking about the DHP type of calcium channel blocker like your amlodipine or cilnidipine or maybe benadipine in today's world. But yes, we are talking about DHP calcium channel blocker, and beta blockers can be well combined with calcium channel blockers. Of course, we know the rate limiting cardioselective beta blockers, calcium channel blockers like diltiazem and verapamil, really, not to be used with beta blockers, particularly in chronic stable angina patients that we will be reading up subsequently. Particularly your verapamil, absolutely contraindicated to be used with cardioselective beta blockers. Now, bisoprolol and amlodipine is a fixed dose combination, one combination of two drugs targeting three systems. We've already looked at the mechanism of action. So the beta blocker would be blocking the sympathetic nervous system, would be blocking the renin-angiotensin-aldosterone system as well, would be blocking the sympathetic activity, would be reducing the heart rate, accordingly will reduce the cardiac output. And your calcium channel blockers will act on the peripheral vessels, producing vasodilation, of course reducing the afterload and producing the antihypertensive action. So bisoprolol, blockade of the beta-1 receptors in the heart and the kidney. The heart, the sympathetic nervous system would be inhibited. In the kidneys, the renin-angiotensin-aldosterone system would be inhibited, and your amlodipine would be blockade of the calcium influx in the arterial muscle, reducing the peripheral vasculature, reducing the peripheral resistance. And so the combination is an excellent and very prominent antihypertensive combination in a single pill. The treatment of hypertensive patients with a fixed dose combination of bisoprolol and amlodipine, results of a cohort study with more than 10,000 patients. We'll only look at the highlights. So more than 10,000 patients recruited, and 22% of the patients had type 2 diabetes and 38% had cardiovascular disease. Clinically relevant improvement in systolic BP was established in a very high percentage of patients. More than 82% of patients had very significant improvement in the hypertensive control. So adherence is excellent as well and associated with the improvement in the control of previously elevated BP. So 82%, it's a very good response rate when we're talking about a single molecule. And the efficacy and tolerability of a fixed dose combination, a pretty old paper from 2005. I hope I'm audible because my internet connection is showing unstable. Am I audible clearly?
Yes, sir. You are audible.
Efficacy and tolerability of a fixed dose combination of amlodipine and bisoprolol in essential hypertension. Data from the Indian practitioner. Once again, look at the percentage change. This column, in such busy slides, if there's not an option for annotation, becomes difficult. But yes, look at the mean change. Week 1, 10, week 2, 14.29. So very good, proper double digit BP reduction by 8 weeks. All the values are statistically significant. The mean diastolic BP as well. We have already talked in our previous slides. If you are reducing your systolic blood pressure by only 10, we looked at the mortality benefit. We looked at the cardiovascular mortality was already reducing by 13%. If the diastolic blood pressure is getting reduced by only 5, we found that the cardiovascular mortality reduction was more than 14%. If the systolic blood pressure reduction is only 10, then stroke prevention or stroke mortality prevention was 17%, is what we have seen. If the diastolic blood pressure is getting reduced by 5 once again, then severe related death reduction was 18%. And here it is clearly 2-digit diastolic blood pressure reduction with a single molecule. So we can well understand the clinical therapeutic benefit with a combination of bisoprolol and amlodipine. We are moving on to the next section. CCS Guidelines 2019 focus on beta blockers and its combination. So we have done this critical appraisal of the role of beta blockers in hypertension. Uh, why? Because there are a lot of controversy. Essentially, the beta blockers had been moved away from very prominent role in the last few decades to being also ran, as we might call it. It became a fourth line or a fifth line agent. But I hope we have evaluated and appraised the role of beta blockers, particularly in the ESC 2018 recommendation. We have found a very proper place of bisoprolol in resistant hypertension. We have also looked at data to understand that beta blockers have such an important role to play in any stage of hypertension, provided any of those comorbidities are present: atrial fibrillation and coronary artery disease and congestive heart failure, or a young woman or someone planning pregnancy, someone with sympathetic overdrive, particularly the Indian young patients. And such a huge bulk of the Indian patients are young hypertensives. So really understood the role of beta blocker, particularly bisoprolol. Also understood the combination, the impact of the combination of a single pill combination of bisoprolol and amlodipine in scenarios, and what is the potential role on the cardiovascular death, the cardiovascular morbidity, the coronary artery disease associated death, and morbidity as well. So the second part, CCS guidelines. Now this is somewhere the role of beta blockers as anti-anginal drugs require no criticism. It is a well-established fact, but we will try to understand is the holistic approach in the management of CCS, and the drugs that would be added to beta blockers in sequences in different clinical scenarios or different clinico-therapeutic patterns in different patients. The coronary artery disease is a pathological process characterized by the atherosclerotic plaque accumulation in the epicardial arteries, whether obstructive or non-obstructive. This process can be modified by lifestyle adjustments, pharmacological therapies, and invasive interventions designed to achieve disease stabilization or regression. The dynamic nature of the coronary artery disease process results in various clinical presentations, which can be conveniently categorized as either acute coronary syndrome and chronic coronary syndrome. The natural history of chronic coronary syndrome is a dynamic process. Essentially, this is something that we have already discussed. So the higher risk with insufficiently controlled risk factors, suboptimal lifestyle modifications, and medical therapy, large area at a risk of myocardial ischemia, and the lower risk with optimally controlled risk factor, lifestyle changes, adequate therapy for secondary prevention, example aspirins and statins and ACE inhibitors and beta blockers, and subsequently appropriate revascularization if that is required. Now the sixth, coronary syndrome, and this is the approach used in the ESC, ESH, as we have repeatedly seen. So what would be the different index cases, if we might call it that? One would be a patient with, so essentially this is talking about the different permutations and combinations of chronic coronary syndrome patient with which you might get a patient. So first one would be a patient with say suspected CD and stable anginal symptoms and or dyspnea. Two, what would be the role of beta blocker in such a case, which beta blockers to choose, along with bisoprolol, the role of carvedilol and metoprolol, and where bisoprolol really stands out. Patients with new onset of heart failure or left ventricular dysfunction and suspected CAD, and we need to understand the role of beta blockers in such cases and what would be a second or third line agent. Patients with stabilized symptoms less than 1 year after an ACS or patients with recent revascularization. Patients more than 1 year after initial diagnosis or revascularization. Patients with angina and suspected vasospastic or microvascular disease. Microvascular disease, as we know, would be patients with angina whose coronary angiography do not reveal abnormal coronaries. This is the same thing that previously was called the cardiac syndrome X. We have a slightly better term now. The microvascular angina would be one place where now nicorundil has a very important role to play. Vasospastic angina is something that we used to call up Prinzmetal's angina, and yes, where the drug of choice would probably be amlodipine. And asymptomatic patients in whom CAD is detected at screening. So the approach for the initial diagnostic management of patients with angina and suspected coronary artery disease. You start with your assessment of symptoms and perform the clinical investigations. Step 2 being consider comorbidities and quality of life, the resting ECG, biochemistry, chest X-ray in selected patients, assess the pre-test probability and clinical likelihood of CAD and so forth, and so on and so forth. Now, in spite of this, this is from EAC 2019. Just to recap this a bit, because once again, this is a slightly busy slide. We'll try to make it very clear. Now, in a case of suspected chronic coronary syndrome, how do we really go about in today's world? At the end of the day, initially, it's always the clinical diagnosis. So we need to establish whether the chest pain, we are not really talking about screening here, because we can always have a patient who was otherwise stable, had no symptoms, a completely asymptomatic patient, maybe had a planned surgery, went for evaluation, there were some issues noted, patient underwent further evaluation and investigation, and a CCS was established. We are not talking about such cases. We are talking about symptomatic or mildly symptomatic cases. You start with the establishment of whether the chest pain that the patient complains of can be either of the three types. It can be a classical cardiac chest pain, it can be a non-classical cardiac chest pain, and it can be a non-cardiac chest pain. We are not going to details about how to understand the classical chest pain, which areas involved, whether the chest pain is in the precordium or inner aspect of the left arm, or radiation along the carotids, or pain in the lower incisors. We are not going there. Now, essentially, in such case, would start with the first or the second line anti-anginal drugs. This is not the place where you go for further evaluations. Obviously, you need to rule out ACS in such patients first. Now, if the patient is inadequately controlled, now understand your anti-anginal drugs are only the beta blockers, the beta blockers, the cardioselective calcium channel blocker, or the non-DHP calcium channel blocker like diltiazem and verapamil. The third would be the long-acting nitrates. The fourth, fifth, or sixth interchangeably would be your trimetazidine group, your nicorandil group, your ivabradine group, and your and ranolazine group, the PFOX inhibitors. However, before going on to your third line agent, it is at this point the coronary CT angio becomes an important tool. Kindly note that the role of treadmill test and such other similar either invasive test or test which increase the risk of an ACS are things which are slightly being moved away from the present world. As in, the treadmill test was a part of most guidelines, including but not limited to NICE guidelines till a very recent past, but they have been removed from the recommendation list as of now. Now, with this basic understanding of the initial evaluation of cases of CCS, we move further into the pharmacological management. To reduce angina symptoms and exercise-induced ischemia, and to prevent cardiovascular events, the immediate relief of anginal symptoms or the prevention of symptoms under circumstances likely to elicit angina is usually obtained with the rapidly acting formulations of nitroglycerin. The anti-ischemic drugs and also lifestyle changes and your anti-ischemic drugs all play a role in minimizing or eradicating symptoms over the long term. The prevention of cardiovascular events targets MI and death associated with CAD and focuses primarily on reducing the incidence of acute thrombotic events and the development of ventricular dysfunction, where your ACE inhibitors and ARBs have a very prominent role to play to prevent the risk of cardiac remodeling. So the optimal treatment can be defined as a treatment that satisfactorily controls symptoms, prevents cardiac events associated with CCS, maximum patient adherence, and minimal adverse events. Now, something very important to understand would be that in cases of CCS, see, whenever we are talking about other modalities, when we are talking about other risk groups, when we are talking about other disease, the one factor that we keep harping on is the cardiac mortality benefit. So when we are talking about post-ACS patients, when we are talking about coronary artery disease patients, when we are talking about congestive heart failure patients, now essentially we always look at the cardiac mortality benefit. Now understand this, in CCS, the anti-anginal drugs that we use in CCS, we are not talking about the association of CAD, we are not talking about the association of CHF, we are talking about only CCS. Understand this, the anti-anginal drugs are anti-anginal drugs, that is, they reduce the pain, they reduce the angina. Establishment of cardiac mortality benefit is not an issue with CCS. The drugs which actually reduce mortality would be the aspirin, the statin, and for that matter, ACE inhibitor ARB. But the anti-anginal drugs only reduce the angina. They do not have a well-established mortality benefit in CCS only. If the CCS is associated with other things, if the CCS is associated with congestive heart failure, if the CCS is associated with arrhythmias, that's a separate story. But CCS only, we look at the anti-anginal action of the anti-anginal drug and not the cardiac mortality benefit. It's a slightly anti-intuitive finding, because in cardiology we more often than not tend to look at the cardiac mortality benefit, but this is slightly differing as far as the concept of CCS management is concerned. There is no universal definition of an optimal treatment in patients with CCS. Drug therapies must be adapted to patients' characteristics and preferences. So we will look at the expected tolerance. Yes, of course, we look at nitrates, and tolerance is a very important issue with nitrates. The comorbidities, the potential drug interactions, patients' preferences, and drug availability as well. So the suggested stepwise strategy for long-term anti-ischemic drug therapy in patients with CCS has specific baseline characteristics. So the first step would be a beta blocker or a calcium channel blocker. The second, as far as standard therapy, and if you're looking at the next line agent, the second step, the patient is inadequately controlled. So let us be very clear about this. What is your first step? Your first step would be a beta blocker. What is your choice of a beta blocker? We are discussing Misoprolol, obviously. So Misoprolol, Carbidopa, and Metoprolol. If you want to use a calcium channel blocker as a first line agent, it would be a non-dihydropyridine calcium channel blocker like diltiazem or verapamil. But if your patient is inadequately controlled with a first line agent, then your second line agent would be, if the patient is getting beta blocker, you cannot add a non-DHP calcium channel blocker because that increases the chance of cardiac arrest, third degree heart block. You then have to give a dihydropyridine calcium channel blocker. You cannot give a non-dihydropyridine calcium channel blocker. And if the patient is inadequately controlled on the two combination of drug, then you add what we call the second line drugs, and that second line drug can be a long-acting nitrate, it can be ivabradine, it can be trimetazidine, it can be ranolazine as well. If the patient has high heart rate, once again, what is the first step? The first step, obviously, intuitively, it would be a beta blocker or a non-dihydropyridine calcium channel blocker. Second step, now this is an issue. Yes, if the heart rate is high, can you use a beta blocker and a non-dihydropyridine calcium channel blocker? ESC tends to suggest so. Please hear from me that most guidelines have a strong apathy of combining beta blockers with a non-dihydropyridine calcium channel blocker. Particularly combining beta blocker with verapamil, this is contraindication in NICE guidelines, and they have very strong reservations with the use of diltiazem as well. So second line agent or a third line agent would be another agent that is a negatively chronotropic agent like ivabradine. It becomes a very good choice if the heart rate is more than 80. And we've already looked, if the heart rate is high in a patient with CCS, in a patient with coronary artery disease, in a patient with heart failure, the mortality is increasing greatly. Heart rate more than 100, we did see that the relative risk for death was 3.4. Whereas in a heart rate between 60 and 80, the relative risk for death is only 1.42. That is something that we've already seen. If your patient has a low heart rate less than 50, the first step can be a dihydropyridine calcium channel blocker. Definitely not a beta blocker. Heart rate less than 50, it's really a contraindication to use a beta blocker. And inadequately controlled, then the second line agent would be a long-acting nitrate. What can be a third line agent? Combining the dihydropyridine calcium channel blocker with a long-acting nitrate. And what can be the fourth step? You still do not use a beta blocker. Of course, you still do not use a non-dihydroberidine calcium channel blocker. Of course, you do not use a ivabradine because that can also reduce the heart rate. So you use the other molecules, namely corandil and ranolazine and trimethazine and so on and so forth. If there is a left ventricular dysfunction or heart failure, of course, beta blockers would be an excellent choice, and such patients should also be getting your ACE inhibitor or ARB. But ACE inhibitor, ARBs are not anti-anginal drugs. We are discussing anti-anginal or anti-ischemic drugs. What can be a second line option? It can be adding your long-acting nitrate or ivabradine. So we can go on and on and on and on with it. We have a very classical, what we call the diamond approach. In NICE guidelines, we have that diamond approach. We are not going to diamond approach now. Essentially, that means the use of the different kinds of agents together. But we have some idea about how to go ahead with this. So various mechanisms of the action of beta blockers in coronary heart disease: regression of the atherometastasis process, reduced rate of reinfarction, reduced infarct size, and risk of cardiac rupture. They increase the threshold to ventricular fibrillation, something that we've discussed. A reduction of platelet stickiness. We've already talked about the role of beta blockers in platelet dysfunction and endothelial dysfunction as well. Reduced myocardial oxygen requirement, reduces the heart rate, reduces the cardiac output, reduces the stroke volume as well, and reduces the systolic pressure, reduces the ventricular contractility. Essentially a negatively inotropic and chronotropic action as well. Reduced arrhythmogenic free fatty acids and redistribution of the coronary blood flow. The dose of beta blockers should be adjusted to limit the heart rate between 55 and 60, because we've already seen if the heart rate is less than 50, your first line agent is no longer a beta blocker. In fact, in a patient with CCS, the only place where the target heart rate less than 50 is the only indication where beta blockers are no longer first line agents. So target heart rate would be between 55 and 60. Discontinuation should be tapered and not abrupt. Increases the risk. If you are tapering it suddenly, it does increase the risk of arrhythmias. Combination of beta blockers with a nitrate attenuates the reflex tachycardia of the latter. So beta blockers in CCS survival in certain patients. Please note this: in certain patients, the anti-ischemic drugs, whatever anti-ischemic drugs we use, the mortality benefit is not the primary issue. The anti-anginal action is the primary issue. But in certain patients with recent MI, those with chronic heart failure with reduced ejection fractions, in such patients, beta blockers have been associated with a significant reduction in mortality and cardiovascular events. But the protective benefits in patients with CAD without prior MI or heart failure is less well established and lacks placebo-controlled trials. In patients with or without previous MI undergoing CABG, beta blockers were associated with a lower risk of long-term mortality and adverse cardiovascular events. Long-term beta blocker therapy and clinical outcomes after acute myocardial infarction in patients without heart failure. The nationwide cohort study, what we found that if the post-MI, the beta blocker therapy is less than 1 year, then the adjusted heart rate, the adjusted hazard ratio since 1 year after MI, if you're looking at all-cause death, look at this. If the therapy is for more than 1 year, look at the hazard ratio for all-cause death. It is 0.81. That is 19% relative risk reduction. If you're looking at a patient with recurrent MI, then the chance of a recurrent MI, if the therapy has gone for more than 1 year, then the relative adjusted hazard ratio is 0.82. So the relative risk reduction is 18%. Yes, the hospitalization for heart failure is non-significant, but once again, look at the composite income. In the group which has undergone beta blocker therapy for more than 1 year, the composite outcome is hazard ratio is 0.82. So once again, the relative risk reduction is 18%. So very significant improvement if a long-term post-MI beta blocker therapy is undertaken. Calcium channel blockers in chronic coronary syndrome. While the calcium channel blockers improve symptoms and myocardial ischemia, they have not been shown to reduce major morbidity endpoints or mortality in patients with CCS. We keep on repeating the same point that these are anti-ischemic drugs or anti-anginal agents. They are used to reduce the pain. The target is not mortality benefit. But yes, in certain subgroup of patients, we have seen mortality benefit with beta blockers, but not with calcium channel blockers. Verapamil has a large range of approved indications, including all varieties of angina, supraventricular tachycardia and hypertension. but beta blockade combined with verapamil is not advised due to risk of heart block, third degree heart block, as we have just mentioned. There have been no outcome studies comparing diltiazem and verapamil. In some selected patients, non-dihydropyridine agents may be combined with beta blockers for the treatment of angina, but yes, it is pretty risky. However, on such occasions, they must be used under close monitoring. A very important issue of patients' tolerance regarding the excessive bradycardia or the signs of heart failure. Use of non-dihydropyridine calcium channel blockers in patients with left ventricular dysfunction is definitely not advised. In fact, combining with verapamil is absolutely contraindicated. Clear-cut recommendation is there in the NICE guidelines. Yes, with diltiazem, theoretically it may be used, but pretty limited data. And in today's world, when you have so much other drugs, so many other groups of agents with good data in combination with the cardioselective beta blockers, why go for a slightly sinister option where there is a risk of complete heart block? So the dihydropyridine calcium channel blocker, nifedipine. In fact, in NICE guidelines, it is indeed nifedipine that is clearly recommended. Well tested in hypertensive anginal patients when added to beta blockade. In large placebo-controlled the ACTION trial, addition of long-acting nifedipine to conventional therapy of angina had no effect on major cardiovascular event-free survival. The long-acting nifedipine proved to be safe and reduced the need for coronary angiography and cardiovascular interventions. The very long half-life of amlodipine and its good tolerability make it an effective once-a-day anti-anginal drugs. In fact, amongst the calcium channel blocker, it is the amlodipine that is truly a 24-hour molecule. Others are not really 24-hour molecules, setting it apart from drugs that are taken either twice or three times daily. Side effects are a few, mainly ankle edema. In patients with chronic coronary syndrome and normal BP, 75% receiving a beta blocker, amlodipine 10 mg per day reduced coronary revascularizations and hospitalizations for angina in a 24-month trial. So we, just like your nifedipine, there is data to support the use of amlodipine, the dihydropyridine calcium channel blocker, as a first or second line drug, combination drug, or add-on drug in management of CCS. However, the calcium channel blocker and beta blocker combination is often underused, and it's a fact, even in some studies reporting optimally treated stable effort angina. This is the classical diamond approach, very popular approach if we go by the NICE guidelines. But yes, the green ones are very suited combinations. So beta blocker, combining a beta blocker with a nitrate or a dual acting agent like a nicorandil, or beta blockers with calcium channel blockers, or nicorandil or nitrate with ivabradine, beta blockers with calcium channel blockers. So once in green, deep green, these are the combinations which are very suited indications. So of course, you can see the deep red is something that you are not supposed to use. So beta blockers with diltiazem and verapamil, that is non-dihydropyridine calcium channel blocker, there is a very high risk of third degree heart block. Ivabradine, another drug which is a bradycardiac agent, if you might call it that. So even combining ivabradine with diltiazem and verapamil is a very risky approach. The other ones, the lines in blue, are the ones that are very viable options, very good options, but as third line agents, that is after failure of first or second line agents. And always note that when you are adding the third line agent, that is the time you have to evaluate the patient further. The recommendation the recommendation of the third line is when the patient is awaiting a coronary CT angiography. So the moment you are writing the third line agent, you should already be sending the patient for further evaluation with a coronary CT angiography. This is the guidelines from NICE. So beta blockers and calcium channel blockers, very attractive options. Suggested stepwise therapy for CCS is something that we have already discussed. We have talked about the different aspects of this guideline, and we will just highlight towards the end, very much towards the end of our session. So recommendations on the anti-ischemic drugs in patients with CCS. First line treatment is indicated with beta blockers and calcium channel blockers to control heart rate and symptoms. If angina symptoms are not successfully controlled on a beta blocker or a calcium channel blocker, the combination of beta blocker with a dihydropyridine calcium channel blocker, not a non-DHP calcium channel blocker, an initial first line therapy with the combination of beta blocker and a dihydropyridine calcium channel blocker should also be considered. Long-acting nitrate should be considered as second-line treatment option when the initial therapy with a beta blocker or a non-DHP calcium channel blocker is contraindicated. poorly tolerated and inadequate to control the angina symptoms. Beta blockers are recommended in patients with left ventricular dysfunction or systolic heart failure. Also note that in a patient with left ventricular dysfunction, you absolutely should not be use a non-DHP calcium channel blocker. In patients with a previous STEMI, long-term oral treatment with a beta blocker should be considered. And we have really looked any case of post-MI, post-ACS patient, be it with hypertension, be it with CCS, beta blockers of course become a very important drug in your armamentarium. Beta blockers are recommended as essential components of treatment due to their efficacy in both relieving angina and reducing mortality and morbidity in heart failure. So if the patient also has heart failure, beta blockers automatically not only become excellent anti-ischemic, anti-anginal agents, but they actually provide cardiac mortality benefit, unlike other group of drugs in the same class. Hypertension recommendation for hypertension treatment in CCS. In patients with symptomatic angina, beta blockers and calcium channel blockers are recommended, something that we've also seen when we were discussing the role of beta blockers in hypertension. So therapeutic goal would be reducing the frequency of angina, reducing the severity of angina, increasing the exercise capacity without significant side effect. Please note, the primary therapeutic goal is not mortality benefit. The primary target is not reducing deaths. The primary therapeutic target in CCS is reducing the frequency of angina, reducing the severity of angina, and increasing the exercise capacity of the patient. So the choice of an agent would depend on your pharmacokinetics, and we have already talked about this. Not only beta blockers like Misoprolol, but when we are choosing your dihydropyridine calcium channel blocker agents, other dihydropyridine calcium channel blocker like Nifedipine, which is definitely indicated as an anti-ischemic agent. Please note, Amlodipine would be an agent which is a truly once daily calcium channel blocker. Other calcium channel blockers are not really true once daily calcium channel blocker, and there can be a definite time throughout the 24-hour period when the patient is without the anti-ischemic effect of the dihydropyridine calcium channel blocker for all other dihydropyridine calcium channel blockers other than amlodipine. Yes, of course, beta 1 selectivity, adverse event profile, comorbidities are important issues to be taken care of. Thank you so much. We are at the end of a pretty long session and we are now open to questions.
Thank you, sir. Thank you so much for such a nice presentation. I think it's a wonderful and very, elaborate presentation, rather I should say. Each and every slides you have elaborated wonderfully. I think whoever the attendees are here, doctors, few of your colleagues and few of my internal colleagues, they got a lot of insights from your presentation. So there are few of the questions in the chat box. If you allow me, I can read it out for you, or you can
I
take
can
it
read
of
the
your own.
questions. I can read the questions.
Okay, sir. Okay.
Right. First question from Dr. Mondol, I believe. Doctor, in treating
Yes.
patients of CAD patients with which beta blocker you find better? Okay, is this the question to me as what I find better? See, I'll give you a very specific answer pertaining to this. This is not a kind of question that I enjoy. We always go by guidelines, we always go by evidence, sir. And what in today's world we are as physicians, we follow evidence-based medicine. And what is the level of evidence, what is the highest level of evidence, and what is the lowest level of evidence? Your highest level of evidence would be meta-analysis of randomized control trial. Your second level of evidence would be randomized control trial, followed by non-randomized control trial, followed by a prospective cohort study, followed by a retrospective case control study, followed by case series, followed by case studies, followed by expert opinion. So in this huge hierarchy, the lowest level of evidence is expert opinion. And answer, I am not an expert. So what I find better hardly makes sense. If you look at guidelines in the management of CAD, the three beta blockers, your bisoprolol, carvedilol, and metoprolol. We don't really have a head-to-head data pertaining to this. Yes, with metoprolol, we have certain conflicting issues which I'm not taking about this particular point, but since you're asking which you find better, for me, it is absolutely bisoprolol. It's not because I'm doing a presentation on bisoprolol, but yes, the data that you have in support of bisoprolol far outweighs, not far outweighs, but outweighs data. But we do not have a head-to-head trial. We do not have a study which is comparing carvedilol with bisoprolol. We do not have a study which compares bisoprolol with metoprolol, or for that matter, your carvedilol with metoprolol. We do not have that. But this is a question which, in evidence-based medicine, should be done away with. Because even an expert opinion, and I'm not an expert at all, but even an expert opinion, this is the lowest level of evidence. What I say makes no sense. What ESC says is the highest level of evidence. What ESH says, what NICE guidelines says is the highest level of evidence. Okay. Another question from Dr. Garg, I think. Yes. Each beta blocker are similar but not the same, and all have different pharmacokinetic variabilities. Does this matter in selecting a suitable among available beta blocker? If yes, please suggest how to choose best one indication wise. Okay, once again, if I believe you are talking about cardioselective beta blockers, because if we think about all the different indications of beta blocker, then we will have to remember from our pharmacology days the role of propranolol, right? Because it's a non-selective beta blocker, as we know, and the different issues, be it thyrotoxic stage. What is your ideal beta blocker? Say, basically, when we think about propranolol, it has fallen out of favor, right? But if you're talking about the indication of beta blocker, think about your panic attacks. Think about your GAD patients, generalized anxiety disorder patients. Think about a case of thyroid storm. Think about a case of thyrotoxicosis. Think about migraine. So these are actually all of these are indications of beta blockers, right? But jokes apart, I believe your question is pertaining to cardioselective beta blockers. And once again, we saw that in a very important recommendation on the 2018 ESC, one particular beta blocker is being recommended for resistant hypertension, and that is bisoprolol. That is not any of the other beta blockers like an atenolol or a metoprolol or a carvedilol in that particular case. Yes, in CCS, NICE does not recommend one beta blocker of the three out of the other. The three beta blockers with established cardiac mortality benefit in heart failure, three beta blockers with established mortality benefit in post-MI patients would be bisoprolol, carvedilol, and metoprolol. Yes, I believe in SIGN there is a place for nebivolol as well. Not going there, but yes, one particular area, as we have mentioned, the 2018 recommendation does talk about that one particular beta blocker, that is bisoprolol. And other indications, I'm not really going into the non-selective beta blockers like propranolol, we know about it. Okay, dear doctor, in your day-to-day practice in stage 2 hypertension, which beta blocker plus calcium channel blocker combination you preferred? I will give a very honest opinion pertaining to this. In spite of the data that I have presented, my choice of using a drug for a stage 2 hypertension or inadequately controlled with a first line agent, ACE inhibitor ARB, would be adding a calcium channel blocker. So my drug choice for a stage 2 hypertension, still, since you are asking me the question, it is ACE inhibitor ARB plus a beta blocker, and the third line agent, essentially because even from my degrees, as you see, since my studies along the Royal College lines, so NICE is a very favorite guidelines of mine. I have strictly stuck to NICE guidelines from the day of my Royal College fellowship. So it is as second line agent, it is still ACE inhibitor ARB plus a calcium channel blocker. Third line agent would be a thiazide like diuretic like chlorthalidone or indapamide, and followed by that, depending on the potassium values, if the potassium value is more than 4.5, this is when I personally use the beta blocker, and if the potassium level is less than 4.5, I choose the spironolactone. This is clearly the nice guidelines that we have at hand. Okay, that brings us to the end of the question. No other questions? Hello?